I'm Jody Goodkin. I will be your presenter today for spine surgery, operative and postoperative management of degenerative disorders. I have been a physical therapist for 30 years, involved in physical therapy education for over 20, and I look forward to discussing this topic with you today. In this course, we are going to examine the contemporary information, all of the current literature that I reviewed related to the operative as well as postoperative management of specifically orthopedic disorders of the spine. We will look at the different vertebral decompressive procedures, stabilizing procedures, and examine how those are performed and considerations we should have when working with those patients postoperatively. The rationale for this course is to look at the current trends in the management of those non traumatic orthopedic compressive disorders, specifically focusing on the cervical, thoracic, and lumbar regions, so that you have a sense of the current literature and what the trends, and then what's emerging as the future of these surgical interventions. To accomplish this, our goals and objectives are aligned. During our first hour, we'll take some time and review the pathologies that lead to these nerve compression conditions related to the spine. We'll review the general components of the different hardware and instrumentation that is utilized, and then some of the different commonalities among all of the procedures. In our second hour, we'll specifically look at the cervical and thoracic procedures and post op considerations. And then during our last hour, we will take a look at the lumbar procedures and their considerations, as well as future advances. As with any course you attend, application of the concepts that we're presenting is when you go back in the clinic to be applied within accordance of your federal, state, and professional regulations. There is no conflict of interest for the presenter or the provider of this course. As we work through our presentation, you will see that several of the slides on the bottom left-hand side have this orange icon that says consider this. That's to let you know that those particular slides are going to be helpful when you go to complete that course post test later on today. We'll start with a basic review of our spinal anatomy. We know that when we look at the spine, structure supports function, that we have our natural curves in the spine of a lumbar and cervical lordosis, and then a thoracic kyphosis and sacral, so that our body is able to support the weight that is placed upon it. If we look at the basic functional unit of the spine, we're looking at this lumbar example here. So we are seeing that our basic functional unit of the spine is going to encompass the superior and inferior vertebrae, as well as the disc that's located between it. The way that this is designed is because we have so many forces going through our spine that about 70% of the weight bearing forces are taken through the vertebral bodies and the discs, and then through our facet joints here, about 30% goes through those facet joints. And that's going to be important to understand when we look at the development of disease and then the surgical procedures. If we take a look at this image on the left, we're examining that vertebral arch. So we have that vertebral foramen that is created in order to allow passage of the spinal cord. And we specifically have between the vertebral body and the transverse process that is going to be our pedicle. And we'll talk about that related to screw placement for stabilization. And then between the transverse process and the spinous process, that is where we have our lamina. And we'll look at laminectomies and removal of that specific wedge of material of bone here in order to relieve compression on that spinal cord and nerve roots. Looking at more of a sagittal view, When we look here from that sagittal plane and we look at the superior and inferior vertebrae, we have this intervertebral foramen that is created where our spinal nerve roots are going to be exiting. I'll circle one here. So our spinal nerve roots are going to exit through here to go out and innervate those different regions. One structure that I want to bring up, depending on uh, kind of when you were educated, we were more or less aware of how important the uncovertebral joints were in the cervical spine. Those are located between C3 to C7. And those particular joints are, if we look at this view, we're looking at the top edge of the vertebral body. I'll kind of go just below it. It almost looks like a smiley face. It looks slightly cupped. I'm showing you on a lumbar vertebrae because it's larger and easier for you to see. I know that this is lumbar and I know that this is not where those joints are located. So we're just looking at our surface area here if this was a cervical vertebrae. So when we look at that superior aspect, it's like coming up here on the sides, just slightly of that superior surface of the body. There are little pieces of bone that kind of cup up, and those develop during the first 12 years of life from that cartilage region. And what they're finding is those play a role here in helping limit those lateral movements. It also extends the surface area of those cervical vertebral bodies that tend to be a little bit smaller. Related to what we're talking about today, they become a little bit of a challenge because as there is degeneration in that cervical spine, we're going to see them as a site where more osteophytes can form. And because of their location, here I'm drawing them all down in blue, we can see that they can really encroach upon these nerve roots that are trying to exit. So we're seeing those become more of a focus as they look at different surgical procedures. And I wanted to just review them so that you are familiar as you read the research moving forward. We have many different ligaments that are supporting our different movements of the spine. If we look starting, we're going from anterior to posterior. This image mimics the spine here. As we look at that anterior aspect of those vertebral bodies, we have our anterior longitudinal ligament. So that will become taut when the individual goes back into extension. So it'll limit those movements. Then, if we keep moving back, we have our vertebral bodies and our discs. And then behind them, actually located in that vertebral foramen, running down in here in this area on that posterior aspect of the vertebral bodies is our posterior longitudinal ligament, and that is going to become taut when the individual moves into flexion to limit those movements. Now what you see here is we have that posterior so we have the bodies and the discs. Then we have that posterior longitudinal ligament. Then we will have our spinal cord that I'm showing here in yellow. So you can see how intimate and close that is. So when we look at the disease process, it's going to be important to remember this relationship because that posterior longitudinal ligament fibrosis plays a role in stenosis. Next, if we're going back posteriorly, we are going to have our ligamentum flavum here. And these are going to be paired ligaments that are located between those lamina of the adjacent levels. And those ligamentum flavum are highly elastic. They're very thick. They're going to limit those movements of the spine. And again, they're very close to that spinal cord. When they're functioning normally, those are going to help stabilize and not encroach upon the spinal cord because as we flex and extend those ligaments, when you flex forward they may bend into the spinal canal a little bit, but because of their high content of elasticity, as you go into extension they pop back so they're not compressing on that spinal cord. As we see degeneration, their ability to pop back at a space to not compress the spinal cord becomes limited. So again, those are a culprit in our spinal stenosis that we're seeing. When we look at the different degenerative conditions of the spine, spondylosis is that general term, kind of the umbrella term for different degenerative conditions that lead to that progressive neural compression, pain, then sensory, then motor impairment, and reflexes become impaired also that limit the function for the individual and their quality of life. So, our goal here is really, whether we're conservative or surgical, to improve all of that for the individual. Under that umbrella term of spondylosis, we have two different specific conditions: degenerative disc disease and then facet osteoarthritis. Degenerative disc disease is looking at that actual height of the disc, and we can see here in this example, it's significantly degenerated, that it is going to compress down. And then facet osteoarthritis is looking at those facet joints and osteophyte formation and degeneration and osteoarthritis in those areas that destabilize the segments. So we've lost height that compresses on this nerve. We're destabilized, that allows slippage and movement. We have osteophytes that are moving and encroaching on the spinal cord and the nerves. And all of this together lead to that stenosis and spondylolisthesis, where there is that forward slippage. And that's what we're seeing here at the end of this arrow in the image. So here is our superior vertebrae, and then the inferior vertebrae is here. If we look at the anterior aspect, we can see that this is slipped forward. And again, as that slips forward, that's going to stress the spinal cord. Believe it or not, that is the oversimplified explanation of what's happening to our patients. And it's important for us to understand the disease process, not only because it gives us more insight as we're looking at our patients during conservative management, when we look at the continuum of progression, why some individuals are more responsive than others, but also to understand the surgical procedures and where the physician is going in to make changes to relieve that compression. And then that directly leads us to the potential complications and the precautions that we need to think of during rehab. So it always comes back to this anatomy and understanding the process. If we look specifically at degenerative disc disease, what happens over time because of aging, because of trauma, different stresses that have been placed upon that disc, what we see occur, this one's a little more intact, that the stress is placed upon this disc. And naturally, as the individual ages, that high water content of 80% in that nucleus pulposus tends to decrease. And as that nucleus pulposus loses some of its integrity, it's unable to accept the different forces that are placed upon it. The example that we always used when we're teaching students this for the first time is what? The jelly donut. That it is drying out inside there, compressive forces place on it, and then those annular rings, the donut part, those become weaker. They tend to fibrose as we age and weaken. And then, as there's excessive pressure, that is going to press that annulus out. And now it's going to encroach either on the spinal cord or into that exiting spinal nerve as we have that transfer of forces. Well, now we have that disc that's not doing its job. It's not absorbing the different stresses. And because of this degeneration here, now where that 70% of the forces are supposed to go through, it's not working. So at that point, we're having the stress that's going to be transferred to these facet joints. And now we're going to see degeneration of those facet joints as they try to make up for the disc that's not functioning. We start to see that disc with degeneration, it starts to infiltrate into the subchondral space. We're seeing osteophyte formation, degeneration, and different changes that sometimes they're referred to as modic changes. On imaging of those actual discs. Now, as everything becomes destabilized, you can imagine the ligaments are working harder, so they become fibrotic. We're seeing the stenosis and spondylolisthesis. The morphologic changes on examination, looking at that actual disc, it can become protruded. There's sequestration where there's little fragments of that disc that can come out into the space. We're seeing that in the circle here and here. The osteophytes, those extra bone formation on the vertebral body, the facet joints, the uncovertebral joints, of all those structures that we already looked at. And then I mentioned that those ligaments are working harder. So the ligamentum flavum hypertrophies, it becomes bigger, it becomes more rigid. It's not moving out of the way for that spinal cord during motion. The posterior longitudinal ligament ossifies, so that's compressing more against that spinal cord. And this all leads to that stenosis and then ultimately spondylolisthesis, depending on how unstable everything becomes, where we have forward slippage of the vertebral body. When we examine this on imaging, if you are able to see this information preoperatively for your patients, or if you're treating them conservatively, it gives you more insight into where they are in this continuum. So it lets you know, it gives you a little more information about maybe how much you're going to be able to accomplish and how much relief you can achieve for that patient. As we look at the disc is supposed to be heterogeneous. Hetero meaning different. We should see a clear distinction, like in this top left image, of the nucleus and the annulus, because they have different jobs. They're histologically, they should look different. On examination, they should look different. Well, as we move towards degeneration on the right, we see they're more homogeneous here, that we can't really tell the nucleus from the annular rings. And this is where we talked about that they're just not functioning appropriately. The way that this is going to be graded for the individual, the further down we get in the grading, is going to be more collapse, not of height also. And we can see that here on the left images, we're progressively having more collapse. As we get to that grade 5, there's just no disc height that is present any longer for that individual. So we're going to have significant compression on the different structures. That's what's happening to the disc. Concurrently, what is happening as the forces are shifted, if you're able to see these examination results, imaging results, we look at the end plate changes. So that's looking at the surface area here of the superior and inferior surfaces of the bone, kind of looking at those edges of the vertebral body. Normal is going to be our type 1. As we go through our normal aging process, type 2, type 3, kind of small defects or changes in those areas might might happen just because the different forces that are placed upon the individual, but we're not really seeing encroachment on those nerves. Where we really see the changes are moving from type 4 all the way down to type 6. So, this is where, when they look at the surface area of that bone, what percentage of that end plate has those significant defects, where we're seeing the infiltration into that subchondral space. We're seeing that significant changes, not only of the disc, but also going into that bone. And we see this significantly here. They look at how much of that surface area of the bone has osteophytes, has deteriorated, has those different fractures in it, and that nucleus migrates down in there, creates inflammation, creates edema, and again contributes to that spinal stenosis. The other change that we see as everything becomes destabilized is it may reach a point where that superior vertebrae is not sitting directly over that inferior vertebrae, where we start to have, as those facet joints start to give way, as the ligaments are unable to sustain the forces placed upon them, that forward slippage of the vertebral body. Spondylolisthesis, thesis, as we look at this anterior slippage, they're going to grade it based on the percentage of how far the superior vertebrae, how much of the surface area is sticking over the surface area of that inferior vertebrae. So they'll grade that percentage of slippage. And then as it's slipping forward, you're envisioning that spinal cord in here is going to be stressed, as well as these different nerve roots that are coming out. The way this is graded on different imaging is this is going to be related to severe degenerative disc disease. So it's in the later stages. It tends to be more common in the lumbar spine, or at least we hear it discussed more related to the lumbar spine. And those are the diagnoses that we're probably seeing more. The research actually shows that in the cervical spine, it's probably a lot more common, just we do not have as much research that is investigating it. So they're recognizing that this is probably more common in the cervical spine also. When we look at this different grading of the spondylolisthesis and the slippage, that ratio of overhang, a grade 1 to a grade 2, that's considered more of a lower grade slippage, whereas our higher grades are going to be our 3 through 5. 1 and 2 are those patients that may be managed more conservatively, where it's up to a 50% forward slippage of that biomechanical instability that is happening. The grades 3 through 5, these are our individuals who are more likely to need surgery. And if you look at that amount of slippage, you can imagine what is happening to that spinal cord. So at a grade 3, I'll draw lines to show the different two different surface areas here. Um, in grade 4, it's almost falling off. And then in grade 5, there's complete destabilization of that spine. The instability that the individual has, if they're at the lower grades of this, what they may complain of during their different activities is intermittent, non-specific back pain, because again, it's stressing different portions of that spinal cord and nerve roots as it slips forward. It's usually going to be worsened with movement, as it leads to kind of stressing and accentuating that destabilization. And then those 3 through 5 are typically the surgical candidates. For our clinical presentation of degenerative disc disease, we are looking at, as we're already familiar, assessing the dermatomes, the myotomes, the reflexes that are associated with the different levels. We also need to consider, when we're seeing our cervical patients, both pre op and post operatively, that that spinal cord can have spondylolisthesis. It, depending on how the compression is, it is going to affect further down. And we need to be mindful of that post-operatively to assess, not just in our cervical patients, not just assess, the upper quadrants. We really need to look down to the lower quadrants, especially if we didn't see them preoperatively, to know what their pre-existing weaknesses and sensory changes are from the compression and stenosis that they may have. And we need to make sure we're incorporating interventions. And this is where maybe those co treatments really come into play between physical therapy and occupational therapy, because even that cervical patient may need assistance in training with their standing balance, with their ADLs at the sink, not just for the upper extremity component, but also for that lower extremity and trunk weakness that they may have. Something we want to be mindful of with our patients is looking at for potential cauda equina compression. We know that cauda equina is where all of those nerve roots are coming down, that tail at the terminal end of that spinal cord. Compression in this area is considered something that needs immediate medical attention, that we need to refer our patients back for. And again, we're monitoring for this pre op as well as post op. Oftentimes, this is going to initially present as urinary retention. And that's a good way to kind of broach the conversation, because sometimes it is a little uncomfortable for a patient to talk about, well, what is their sensation like in that saddle area? We know that kind of that inner thigh, that genitalia area, we're not going to jump in first with that, asking about it for our patients, because they may not see the relevance if their pain is up a little higher, or if they just had surgery. So, asking if they are maybe not urinating as frequently. As they usually do, as an indicator. And then obviously incontinence and those sensory changes, then we can kind of go into those conversations as needed. Radiculopathy can again present pre-op as well as post-op for everything we're looking at. We want to make sure post-operatively in our patients we're assessing those areas that are directly related to the surgical intervention and level that they had, but also we're going to assess above and below that, just to make sure we have the full picture and we're addressing everything necessary, and to look for any potential complications the individual may be experiencing. Radiculopathy is our lower motor neuron involvement. And don't worry, I won't get too deep here back into the neuroanatomy. Some of you are probably like, wait, this is an ortho course. But we do overlap, right? And we're well aware of that. So, lower motor neuron means that it's after those nerve roots exit the spinal cord. So, either from the foramina region, that's where we're looking at this nerve root, and then it is going to be associated with a specific level of dermatome and myotome that we are going to assess for that individual. Usually, these changes for the patient are distance and time limited. That means that how far down the sensory change is, how long they may be in a position that gives them compression on the nerve, and then they shift to relieve it. In terms of time, with positional changes, we may see a change in their sensory control and their pain. On the other side, we have myelopathy. And the myelo, that prefix we know means spinal cord. So we're looking at an upper motor neuron involvement, because this is actual spinal cord compression for the individual. These tend to be more diffuse symptoms, because we know all of those, depending on what level, cervical down, we have the corticospinal tract, the dorsal column, everything traveling down that kind of intermingles, and we don't know which direction the compression may be in. So we'll see more diffuse symptoms. We're going to see increase in the reflexes because they're not being dampened, as well as clonus. You're going to assess for clonus in the lower extremity at the ankle, and then the upper extremity at the finger, at the wrist. And we also want to monitor for our Babinski. Uh, swiping that lateral medial border of the foot, and then the Hoffman sign in the upper extremity, where we are going to stabilize that middle finger. You kind of come underneath and support the patient's arm and stabilize, and then you're going to flick down the distal interphalangeal joint of that middle finger. And if you see the two finger, index finger and thumb come together, that would be positive for a Hoffman sign, leading us to think that there is some upper motor neuron compression that's happening. And just to distinguish the terminology, so myelopathy is going to be related to this spinal cord compression that we see in this region here. And then myopathy is just muscle involvement. So that's not what we're talking about. That would be disease of the muscle specifically. So, not what we're looking at here for documentation purposes. Neurogenic claudication is another symptom that is more specific to patients with this spinal cord compression. And we need to make sure that we're distinguishing the neurogenic claudication from peripheral vascular claudication. And the hope is that that neurogenic claudication postoperatively is going to improve for that patient as the pressure on the spinal cord is removed. A lot of our patients we know have other comorbidities. So, those that also have peripheral arterial disease may present with peripheral vascular claudication. Here's the difference to remind us. Peripheral vascular claudication is going to be that atherosclerosis, that plaque buildup in the lumen of the blood vessels going down to the lower extremity. This is the individual who is going to walk a certain distance, and as those muscles require increased oxygen and nutrients for that gait cycle, and the vessel is unable to supply that, the individual is going to have pain in their legs as there's ischemia of those specific muscles that are trying to work and are not getting the oxygen that they need. In this case, when the individual rests, the muscles are no longer have that high demand. The normal resting supply through the blood vessel is able to now meet it. So we're going to see the pain that's relieved with rest. That's peripheral vascular claudication. And this is why it's important when our patients, when we're working with them, again, pre and post operatively, if they're only able to walk a certain distance, we do want to question them appropriately to ask, well, what is stopping you? Is it pain? And if it is pain, well, where is that pain? Is it their peripheral vascular claudication, or is it coming from their spine surgery and their pathology there? Because neurogenic claudication is where we're focusing today and working on improving. Neurogenic claudication is in that spinal cord because of all the physiologic and biomechanical changes that occur that we've discussed up to this point, there is compression on that spinal cord and those nerve roots. There's that mechanical compression on them, and we know nerves need nourishment also. They have an oxygen supply, they have vasculature going to them. And if there's compression, typically when the individual is standing up and walking more with that extension and that ligamentum flavum not moving out of the way, creating more compression also, along with the different osteophytes, that this individual is going to have ischemia to that spinal. All right. Sorry. I don't know what just happened there. Um, all right. I think you're still hearing me. Um, so what we are looking at is if we have an individual who has this pain that's relieved by that rest and that relief of their back pain that's happening when they have that little bit of flexion in there, then this is the individual who we know it's more of a neurogenic claudication. And this is something that surgery is also looking at relieving. And when you're writing your goals, when you look at them being distance dependent, it we need to bear this in mind because this may be a variable that comes into play limiting that distance of ambulation for the individual. That covers some of the general pathologies that lead to someone having the need for the different spine surgeries. What we're going to look at now are some of the commonalities among the different spinal procedures. For each, we're going to look at the exposure. How is the physician going to gain access to the specific areas of the spine? Endoscopically, percutaneously, or open. The approach, meaning is it anterior, posterior, what direction are they coming in? The specific structures that we've been talking about that are going to be addressed, and then instrumentation. Those are the different implants and devices that are utilized. As the physician is working in this tight space with all of these different nerves, it's very important that they are informed of how the patient is responding and what how the tissues, I should say, are responding to the treatments that are being done. So intraoperative neurophysiologic monitoring is looking at a way for the physician to have real time feedback of that neural pathway to let them know, oh, well, maybe this is heating up too much from the cauterization and it's causing thermal trauma to that nerve. It's not conducting appropriately. We need to back off a little. Or, oh, is, shifting this tissue causing a trauma to that nerve? They need immediate feedback so they can make changes. To give you an example of how complex this is, the individual on the left here, their head is up in this area, and here we're looking at their iliac crest. This is a 16-year-old who has a severe kyphoscoliosis on the right here. We can see how significant this is. They were having significant respiratory compromise, cardiac compromise, in addition to all of the other symptoms that you would expect. So this individual was really in need of a procedure. So what they did was go in and do a ventral column resection, which is very risky on the right hand side. If we look at that here, all those different nerves to place the rods. So they really needed to monitor to make sure that more trauma wasn't being caused to these structures, and through intraoperative monitoring. Good news here, post-operatively for this individual, below the T8 level post-operatively, there was no sensory or motor, but by 48 hours post-op, T10 had some recovery. And then within a week, there was sphincter control. Within a month after that, there was some hip flexion. So they really did a good job of monitoring this patient during the surgery to have the best possible outcome. The need for this monitoring has been recognized, and in 1990, the American Society of Neurophysiologic Monitoring was founded to come up with standards and standard procedures for this to help support the physician during surgery. The different types of monitoring that are utilized are going to look at the typical pathways that we would think of. We're going to have our sensory monitoring, where there will be peripheral, a stimuli placed for the patient, and then the monitoring will be up in the cortex to see that that nerve is conducting appropriately, and it'll give a readout over here. In terms of motor, they're going to stimulate either in the spinal cord or up in the motor cortex, and then look for that reaction down at the muscle. If your patient has had spine surgery and they're complaining of, kind of their head's a little itchy, or different areas of their body might be a little itchy, it might be because of the adhesive. So don't ignore that if they have an adhesive. Not that you would, I shouldn't say that. We want to be mindful that it could be an adhesive allergy for them, or just to ease their mind if they're like, why is my head itchy when I just had this procedure done? It might be just because of the adhesive and a little irritation. The triggered monitoring is when they go to place the pedicle screws in here for stabilization procedures. If the pedicle screw is drilled a little too far into the cortex, it's going to go into that nerve root or that spinal cord. So what they do is stimulate the tip of the screw and see if they get a readout down here, and that would let them know, oh, we need to back that out a little more. So it's pretty amazing, everything they do. The different types of instrumentation that is utilized. Instrumentation, we know, is that fancy term for the different hardware and componentry that's utilized to achieve the stabilization of the spinal segments to restore that alignment. Typical plates and pedicle screws are utilized on the right here. These are those pedicle screws coming in, and then rods are placed along those in order to help stabilize. This isn't so much going to restore height, this is more just going to stabilize the area. When we're looking at restoring height, it's an interbody cage that is utilized. And on the right here, we see a couple of different examples. They look like that, like exactly like a cage. So there's a space for the bone grafting to be placed into. As they look at these inner body cages, after they decompress and clean out those bone surfaces, we know that bone responds to the stresses that are placed upon it. Obviously, this bone hasn't responded normally, or there's been too many stresses placed upon it that has tried to do its best and failed. Well, when they go in now, they want to cover as much surface area as possible with the cage so that there's equal force distribution and there's not a concern of loosening of that fusion. And this is where they say fusion failure, where it's loosened. And the technology is really looking at cover as much of the surface area so you redistribute the forces as much as possible to try and normalize what is occurring there. One of the materials that they're looking at is called PEEK. It's being utilized more, polyether ether ketone, not a typo. That's what it is. And they find that we know that we need the levels above and below to respond appropriately too. So we don't want to place too much force where the individual can develop adjacent segment disease. Again, part of the redistribution that's necessary. And they want as much of the bone to keep as much of its integrity as possible. Well, if they use metals that are too hard, it is going to take all of the shock and absorption, and then the adjacent bone is just not getting any forces placed upon it. So it's not going to stimulate remodeling and it can become compromised. What they find with the PEEK is that its integrity is more similar to natural bone. So it's able to respond in a more natural manner to give better overall integrity. And they're seeing that there are better fusion rates in those patients that are using these PEEK materials. So you're going to see more discussion related to this. It mitigates more of that stress shielding that can compromise the surrounding bone. So we're looking more at long term benefits here, as well as getting more initial integrity of that good solid fusion for the individual. Then, lastly, we have our artificial discs that we'll look at. If these other procedures are not successful, then an artificial disc may be an option for certain individuals. We're going to take a look at the bone grafting that is utilized within those interbody cages for our different fusion types of procedures. Autografts, those are the gold standard. Those are when the physician is going to utilize the patient's own bone for that fusion. They'll take those different bone chips, like on the right hand side here, and they upcycle, if we want to use newer terminology, where they will take some of the good quality bone that has been removed, maybe from the lamina or the different spinous process components, and clean that out and use that as an autograft. They don't always have to go down to that iliac crest for that live bone grafting. Allografts are another option to provide that scaffolding that the individual cells can then grow into. Regardless of what type of grafting is utilized, they're looking at it has to have very specific properties. We need to make sure that that bone grafting is osteoconductive. When we think of conductive, that means it's going to allow for growth and support, providing a place for those cells to attached to. It needs to be osteoinductive. It's going to need to encourage those different precursor cells to come in to the area to go through that building process. And then it needs to also be osteogenic. In order for bone to form, we need those cells to immediately start differentiating, as well as providing a vascular supply and then mechanical stability. So, all of these reasons are why autographs are the first choice, because they naturally have all of these components. And they're looking at developing different allografts that provide more of these features. And that's when we get into different types of bone graft substitutes. Demineralized bone matrix is one of the more common types. This is utilized during our fusion surgeries in order to allow good stabilization and bone to grow in and solidify in that space where the disc used to be located. It is osteoinductive, osteoconductive properties. And when we look at this, it's formed from different types of human bone by the manufacturers. It's prepared to leave that scaffolding that is necessary for the cells to attach onto. It'll have type 1 collagen in it, proteins, growth factors, a little bit of calcium already there to kind of jumpstart things. Comes in like granules, gels, different formats. There was a study in 2020 that looked at the effectiveness of different forms of demineralized bone matrix from several different manufacturers. And they looked at this in animal studies and they examined fusion rates. Um, Not only on examination of imaging, which is what we're going to look at on the right side of the screen, but they did also look histologically to see about how much fusion was occurring. So on the right here, we'll take a look at the CT imaging because they found a lot of variability in the actual fusion of the bone and how effective it was in creating that fusion. If we look on the top image here, we're seeing a gap where we had some bone bridge that forms across the transverse processes, but then we have gapping in other areas. The next image down, there's actually huge central defects still. So that's not going to be a stable fixation. If we look at the bottom image, there's basically no graft encouragement of ossification in that area. So what they actually found is there was a lot of different performance of these different grafts. This might account, maybe in some cases, how the physician decides from what they've seen in their experience of mobility restrictions, of bracing or not bracing, of their post-surgical protocol. This might be a point of conversation if you're wondering how the physician makes their decision, maybe knowing what they use, if this is a consideration, and could be part of a conversation you have with your patient about, even though you can't see it or feel it, this is what's trying to happen in there, and we need, it's kind of like, I don't know, you can come up with all kinds of analogies, but if you think of a teacup and you're trying to glue that little handle back onto it, and that glue is the bone matrix, too much shifting and moving there, it may not hold. um, so something to consider, they're finding different performance there. They're continually looking for new products. So, cellular bone matrix. This is again an allograft. It's going to, the first component is that demineralized bone matrix that we just talked about. And what they're looking at is adding other components to it to encourage good bone formation. So, to it, they're going to add some actual live bone chips of both cancel and cortical bones so that you already have the cells there to start differentiating. They're going to add osteoblasts, stem cells, different growth factors to encourage not only cell differentiation, but to encourage the blood supply to come into the area that's necessary for all of this to occur. What they're finding is the efficacy of the cellular bone matrix at this point seems to be similar to the autographs. There was a study in 2021 that I found looking at some of the different brands in both human and animal studies. They said the safety isn't conclusive yet. It was a small sample study that was performed. There really isn't an industry standard yet for this, but cellular bone matrix is something that you might see being utilized because it is recognized as increasing cellular proliferation. Where the question still remains is it's not necessarily making a better fusion in the little bit of research that has been done so far. So this is growing. They're trying to get there. Complications that we need to monitor our patients for following their grafting. So we are obviously monitoring where they had their surgical procedure. And then if it's an autograft, we also need to monitor that donor site for infection. If they're having significant drainage from that donor site, pain that's persisting for more than a week, these may be some of those red flags that there might be a deep infection that's located there. In terms of sensory deficits, we're already mindful of whatever sensory deficits they have from their nerve root compression originally. We're going to educate them post-op for safety with their ADLs, not having the water temperature too hot when it hits different parts of their body, for example, or watch what they're leaning against, watch what they're stepping on, make sure they have shoes on, all of those things. But we also need to think about the donor site, that there can be a little bit of transient nerve damage that happens from that autographed donor site. Now, some patients do have pain that lasts 12 to 24 months over where that donor site was. That's in about a quarter of the patients. So we do want to assess for that and address it for the patient to let them know that it's a healing pain and rule out the possibility of infection. We're going to monitor sensation to that lateral femoral cutaneous nerve, to that anterior thigh area, because sensation may be limited. And again, that might not be an area where, if they had a cervical procedure, that they had to be mindful of before with their sensory changes. But now maybe that there's a change in sensation there from the donor site procedure, we need to incorporate that for them. Looking at our allografts, all of that, is tested and processed. We still need to watch that there is a risk of infection at the surgical site. In 2021, there was a batch from one particular batch from one manufacturer of the demineralized bone grafting where there were cases of tuberculosis. So at the one facility that particular batch was utilized, it was utilized on 23 patients. Four of them developed tuberculosis. Another three patients developed other infections. That's 7 out of 23, almost 30%. So while this is rare, it happens. So if something just doesn't seem right, get the follow up, make the other referrals that are necessary. The FDA in this particular case, they said that obviously the patients needed to undergo treatment. Anyone that was exposed during the surgical procedure, clinicians, physicians, etc., needed to go through treatment. So just be cautious that, use your judgment like you always do. If something just doesn't seem right, make that referral, because unfortunately these things do happen. Bone growth stimulators may be utilized for some patients as another adjunct to assist in gaining that solid fusion for stability, to augment that healing for them. They're mostly utilized in patients who are at a greater risk of that pseudarthrosis, someone who is a smoker, if there have been multi-level fusions that are performed, if there is a grade 3 or greater spondylolisthesis where there needs to be a lot of stability, because there was so much realignment that had occurred. Individuals with different vascular disease where there may not be enough circulation or there's concern over that to supply the vascular supply. Internal type of bone growth stimulator is going to be place the electrode, the direct current directly into the fusion substrate, right into that matrix. And then the individual is also going to have implanted the little stimulator. This is usually utilized for the person for 6 to 9 months. The other option is an external type of stimulator. This may be utilized immediately post-operative, or it may be wait a little bit of time before it's prescribed. There are several different versions of it, but the way that the theory behind it remains the same. The example that I have here is of a wrist. I couldn't find a spine one that was not copyrighted. It looks like a brace, and it emits this field, and the idea is that the field that is emitted, the individual wears this brace either for 6 to 8 hours a day for 3 to 6 months, or if it's a different type of current that's utilized, they may wear it 24 hours a day for 9 months. This is looking at trying to encourage the movement of the different substances across that cellular membrane of the osteoblasts to encourage that calcium bonding in the area, increase the blood and lymphatic flow to really encourage that healing and cellular metabolism for a good fusion rate. Some different studies looked at the bone growth stimulators, and there was one out of Korea that indicated there was a 2.5-fold increase of fusion rate when these different type of stimulators were utilized. Another study that I looked at was a retrospective analysis of 11 surgeons in New York who, over 300 patients over a period of 5 years, they gathered data, and they did find that those who did not have stimulation, it took about 8 months for a solid fusion. With the pulsed field, still about 8 months. With the capacitance field, it was 7 months. And then with the combined field, it was down to about 5.5 months. So if you just look at those numbers, you're like, oh, wow, why doesn't everyone just use this? Because there are other additional considerations that while the study found this, again, just myself being a little critical when I was looking at it, I said, well, I would have liked more information on the comorbidities for the patient, more of a cross reference between the different surgical techniques that were utilized for the patient. What type of bone grafting was actually utilized? Was obesity a factor for some of them? Other comorbidities that they may have. So questions there. So I kept on looking, and the 2020 North American Spine Society guideline, let me read it so I have it right. It said that literature yields no studies to adequately address if the use of bone growth stimulators decrease the duration of or intensity of pain or functional outcomes or return to work. So they're saying the research just isn't there yet. But again, you might start seeing it, and this arms you with the conversation to have. And we also want to play a role if it is being utilized, make sure the patient actually utilizes it. Because compliance was another question I had. We'll look now at the specific surgical procedures, first examining the cervical procedures, then going down to our thoracic spine. I did feel it was important to address scoliosis as a pediatric condition, and those kids we may be treating after either from this procedure, or after they heal from it, we may see them for other diagnoses, orthopedic or neurologic, and they become adults that we're going to be treating also. So we want to be have that perspective. Then we'll go down to lumbar and look at disc replacement and a couple of other procedures for compression fractures. First, examining our anterior cervical discectomy and fusion. This is going to be indicated who has that for that patient who has that degeneration of the cervical spine. There are several different approaches that can be utilized. The approach that I'm describing here is the Smith Robinson procedure. The reason I selected this is because it seems to be the most common technique, and it really does a good job of highlighting to us, looking at the anatomy, why we have certain precautions post-operatively and potential complications to monitor for. If this is something that interests you with any of these procedures, a lot of the different manufacturers, they actually have surgical guides, and the American Academy of Orthopedic Surgery. There are all kind of surgical guides that, that's my beach reading, my fun reading. It's just fascinating. I did find an international survey. It's a little old, from 2016, but it looked at 38 surgeons over 67 300 surgeons over 67 different countries. And this is the most common procedure. And I find that important also to look at international research, because we often have an international audience to some degree. And then, a lot of people come to the United States. So we want perspective on what procedures they may have had. So here we go. The anterior surgical procedure. The initial incision is going to go down and dissect that platysma. As that is separated out, what we're seeing in the images here are that the sternocleidomastoid and the carotid artery are moved out laterally, and then that trachea and esophagus are moved out medially in order to expose that anterior area. From this aspect, the physician is able to come right into this anterior aspect of the body for the patient, and they're able to go in and perform that discectomy to clean that out. They can decompress the different surfaces of the bone, taking off the osteophytes and all the different tissue that we discussed through that level decompression, slide right in that cage and graft for the patient. If we look on the bottom image on the right, we're seeing that cage emplaced here. And then on the left-hand side, just adjacent to that, we're seeing what they do over the front. So the cage goes in where the disc used to be, and then putting over the front of that, they have this stabilization plate in order to help retain that lordosis for the patient. Um, they're looking at newer versions where it's one item that can go in to have less moving parts. So you might see some changes there. And again, they're looking at those uncovertebral joints and having different types of grafting and implants that contour better to those areas. If you want to star this slide when we look at the procedure, the concerns post-operatively, remembering that movement of the trachea and the esophagus, that's going to relate to a lot of the precautions and potential complications that we're going to discuss for this population. The other approach is going to be our posterior cervical fusion. In this case, the physician is going to decide to go in posteriorly, and the patient is going to be in that prone position. They need to bisect down through that musculature to dissect it out. So, postoperatively, we're going to need to monitor that closely for potential dehiscence. They'll be able to go in and perform that laminectomy, Fermani, to really clean out the osteophytes, clean out the ligaments in those areas. And then in this case, they're going to insert, as we're seeing here, I'm drawing on the right hand side of the image, those pedicle screws in, and then they'll place the rod in order to stabilize for alignment in this patient. So, really, if you can see the imaging, you will know if a patient had an anterior or posterior approach. Or if you're seeing them later on, if you know where their incision is, you're going to know if they had the anterior or posterior approach that was performed. When the patient is in the prone position, they're going to use some type of clamping system to hold their head stabilized in kind of like that chin tuck position to allow for good stability there. It's called a Mayfield clamp that's located here. So again, if the patient has some, discomfort or maybe little marks or something, we want to do a skin inspection. That shouldn't be there from the clamp, but just to be comprehensive in our assessment. Comparing the anterior and the posterior approach, how the physician is going to decide which way to go, some of the considerations that they're going to have is when they go in from that anterior approach, they can take out that disc, they can clean everything out. And then what will come next is that posterior longitudinal ligament on that posterior aspect of where that disc was removed. So they're able to go in and remove that posterior longitudinal ligament that may be fibrosed, hypertrophied, and creating some spinal stenosis. That sometimes, because of the pathology, becomes adhered down to that dura that is surrounding the spinal cord. So as it's removed, there is a small chance of a cerebrospinal fluid leak. Again, we need to monitor for these things. If there is a cerebrospinal fluid leakage, the patient is often post-operatively very almost immediately going to have those signs of a headache. It's usually going to get worse if they're sitting or standing. That headache will increase. If they have later on, the way that it may present is if the nerve roots become um, kind of protrude through where that little tear is in the dura, then it can create a radiculopathy. So they may have new or radiating pain that just doesn't fit with their recovery pattern as those roots become entrapped. Um, Plus is that there's less muscle disruption. They can really restore that lordosis with that anterior plate. However, it's incomplete decompression because they're not able to get all the way to that posterior aspect. Posterior approach is a little bit different. So the spinal canal is actually enlarged. When they come in posteriorly and they take out some of that lamina, they're able to clean out that ligamentum flavum. They're able to remove that disc in the area. So from posterior, they're able to clean out a lot more of the structures that we discussed. The concern is that posterior longitudinal ligament, they don't touch that, they leave that intact. So the posterior longitudinal ligament is intact. Again, they try to, it's ossified, or they try to clean it out, but it can continue to ossify. You have your spinal cord sitting on top of it with your nerve roots coming out, like my hope this is working for somebody. So what happens is as they remove the bone up top here, the idea is this spinal cord can float away from that ossified posterior longitudinal ligament. So they opened up that area of the spinal cord that was stenosed. Problem is, potentially, as that spinal cord floats away, it can create tension on these nerve roots coming out. So that individual may have a little more axial pain in the area, and we need to monitor them over time for radiculopathy if those nerve roots are, a little bit adhered or getting a little bit stretched. Those complications that we monitor the patient for with our surgical procedures of the cervical spine, dysphagia is the most common complication. Dysphagia is that difficulty swallowing for the individual. This is often because of the swelling in the area, because of that movement that I had to start before of the trachea as well as the esophagus. It's important post operatively that we are monitoring our patients, not only because of the dysphagia, but because of these other potential complications of abscess or hematoma in the pharyngeal area, that we want to look if there's any tracheal deviation. We want to be gently palpating to see if we're seeing any tension developing there that may indicative of that swelling in the area. The dysphagia that happens, that difficulty swallowing, it tends to recover over weeks to month, but in that time we need to be cautious for that patient with, swallowing their pills, with the not dual tasking as they're trying to swallow. It may make it a little extra difficult. Sometimes they'll give them steroids. They may have a little bit of hoarseness also in their voice. Depending on the research that you read, this complication happens in somewhere between 2 and 67% of individuals. So definitely we need to look at this in our patients with anterior as well as posterior procedures, because that swelling and abscess again is a potential risk for patients. But the dysphagia is really the most common, more so with the anterior approach. Looking at the laryngeal nerve palsy for patients, this just happens where they have an inability to scream, they're unable to sing the high notes. Don't think we're asking for that as part of our assessment, but if we notice the patient can't talk higher than a whisper, that may be indicative. That would necessitate a referral to the ENT if we have concerns about that for our patients. There is that risk of esophageal perforation. The images that we're looking at here, again, rare, and this would be further down the line. At the tip of my red line here on left image, we see that hardware that's in place and where it is located. If we come down to the next image, is not here. And when they did a CT of the abdomen, there it is. It had migrated through a little tear in the esophagus down into the patient's digestive tract. Again, really rare, but it can happen where there is that screw migration. So if something just doesn't seem right, again, make that referral. Cervical nerve injury, while the physician is doing everything they can to avoid that, we do want to monitor for it. C5 and C8T1 radiculopathy, I detailed out here. That's already part of your assessment that you're performing. The two I want to highlight are the Parsonage Turner syndrome. This presents in some individuals that it is rare, but it can happen. We want to be armed for those rare cases. The individual may be complaining of shoulder, neck, and back pain that just doesn't fit with their diagnosis or surgical procedure. They may start to develop a winging of that scapula where it's tipping away from that thoracic cavity. It seems to be a delayed presentation of hours to days post surgery. The way you can distinguish the pain here is that the pain is not going to change based on positioning because they're not really sure why this happens, but it is something that occurs to the brachial plexus, the neuropathy that does need to be referred back. Horner syndrome at the bottom here. This is why we're coming in all of our patients looking up at their face. If there is damage to that sympathetic plexus, there is going to be ipsilateral meiosis where that pupil is going to remain dilated. They're going to limit their sweating on that side. They'll have an eye droop on the same side, and endophthalmos, that eye will look like it is more sunken in. Again, referral necessary if you're seeing any of this because there could be compromised to that sympathetic plexus. To brace or not to brace? The general consensus is there is not a consensus, and I can tell you I looked and looked, trying to give you a solid answer. What there is agreement on is why you may or may not use it, the pluses and the minuses. The positives, the idea is that it's decreasing that axial loading for hopes of a better fusion rate for individuals. Most common, if it is used, it's going to be more of that hard collar for 4 to 12 weeks and then going into that soft collar. The thought is that the concern, I should say, if the patient wears it for too long, then it may lead to contracture and atrophy of the musculature. The thought is also maybe it helps manage some of the pain because it's providing stability. Downside, it contributes to dysphagia, that difficulty swallowing, which may already be a potential risk for the patient. Respiratory compromise, so we do need to look at those breathing exercises a little extra if our patient is wearing that cervical collar to make sure we get as much expansion as possible. Skin integrity needs to be a little more closely monitored because they may or may not have intact sensation and may not feel if it's not fitting appropriately. And then our concern in terms of gait and stability because balance may be off. The biomechanical analysis is mixed from all the different studies that I looked at. Some say there's a difference, some say there isn't a difference. Others argue that technology has come so far in the grafting and the hardware that you don't need any external support. Others say yes, but it's not always perfect. We do still need some external support to encourage better grafting. At least you know both sides of the story now, so you can have that conversation with your physician or give some explanation to your patients. In terms of actual research, all of these studies are published since 2020. The first one looking at patients who had 1 to 2 segment stabilization at 5 to 8 weeks of wearing, those patients did have better neck disability index scores. However, the same patients by 9 to 12 weeks out, they did start to have new symptoms that were developing. And they looked at these patients pre-op and then post-op after anterior procedure. So it seems to be like, 5 to 8 weeks seems to be the range of use for those positive benefits if utilized. Another study looking at equivalent outcomes, the ones that were not braced seem to have increased ER visits. But those patients also, if you actually read the study, had more comorbidities. So, where to put that info? Another study looking at a 20-year retrospective analysis with patients with all different types of instrumentation. This one said there were worse neck disability scores with the bracing. There was kyphosis loss and disc space loss without the bracing, so they weren't fusing as much. But ultimately, long term, there was no significant difference. So, have I helped you at all in answering that question? Probably not. I am sorry, but again, points of conversation with the physician that you're working with to understand their reasoning, so you can pass that along to your patients. Post surgical interventions for our patients with the different approaches for the cervical procedures. What we're focusing on with our patients with all different diagnoses really is looking at more non-pharmacologic management of the pain, mindful that these are patients that already had pain and significant limitations preoperatively. Looking at breathing exercises, relaxation, um, just looking at their positioning. Our phones are such a part of our life that, especially if they're not braced, and even if they are, just using that cell phone, we know, contributes to so much to pathology of the cervical spine. They really need to be limiting that use post-operatively, because they may just think, oh, I'm just on my phone, I'm using my hand. We know very well there's so much more that goes into the mechanics of that. So limiting that technology use might be your big obstacle. So if you're seeing those patients preoperatively, educate them and come up with all alternatives for them. Walking programs are the big push for post-op mobility, with attention to shoulder retraction, appropriate neck position, having those scapulas not just back, but also having those relaxed down, trying to relax in to get a little bit of that arm swing for balance. The goal is to work up to that 30 minutes a day to increase that stamina. Breathing exercises, we want to make sure we incorporate our diaphragmatic breathing. For the individual. In terms of activity restrictions, it really seems to vary. There was no one set protocol or no one research study that said, yes, this is the way to go. There seems to be significant variability in the studies I looked at. Some physicians said restricting it to 5 pounds, others were up to nearly 20 pounds the patient was able to move. Looking at the different surgical procedures, some said that you can't go back to sports for 6 weeks, others says 24 weeks, but then some of them said you could do heavy labor at 8 weeks. So we're seeing significant variability. What it comes down to is, again, knowing your physicians, knowing their protocols, because it's all these little pieces that we've talked about that come together. The levels, the material utilized, the comorbidities of the patient that really come together to help make these decisions. One aspect where there does seem to be more agreement is looking at exercise and training for our patients. We know that our postural training is very important. We're avoiding that cervical extension for the patient. And typically, we're not seeing patients until 4 to 6 weeks out for actual exercise. Now, occupational therapy may be seeing them earlier for ADL training, and this is good to know. Depending on your facility, if OT is seeing the patient but PT isn't yet, to have those discussions on, well, what can you start incorporating, because there were different studies that looked at starting rehab and exercises more immediately versus waiting those 4 to 6 weeks. It was a small cohort study of only 30 patients with the anterior approach, and they compared usual care of waiting to actually starting the exercises earlier. They didn't find any difference in fusion rate, which is good because that means it didn't negatively affect the rate of fusion. They had patients just doing basic shoulder shrugs, scapular retraction, shoulder range with that appropriate alignment in all planes, just some gentle cervical isometrics. Where they did find the difference is the exercise group Had lower pain scores at 6 weeks, which means less medication being taken. Now, as they went out to 6 to 12 months, there wasn't as much of a difference in the pain scores, but at 12 months, a year out, they found that less of the exercise patients were using opioid medications, and that is a big benefit. In terms of disability and mental health and physical function, they all ended out the same, but those are some positives along the way. In terms of our different exercises, at whatever point you are going to be allowed to start those based on the physician protocol, we're going to look at that cervical spine stabilization type of exercise. There is no agreement in terms of the optimal program, the optimal timing of the program. Multiple studies we know have shown that training those deep cervical flexor stabilizers, those help with other conditions. So the thought is that incorporating that earlier after the different types of fusion procedures will have a benefit in increasing adjacent joint intradiscal pressure to help stabilize more around that fusion site to hopefully get a better fusion. Exercises that we're looking at in that chin tuck position, looking at doing the scapular motions, doing that transverse abdominis exercise, the drawing in to get recoordinate that cervical and lumbar spine. We may start this on stable surfaces, progressing further into rehab onto maybe a physio ball, more dynamic surfaces. Rowing, we're already doing shoulder external rotation with the arms at side, keep the shoulders down, just doing surgical um, shoulder external rotation, progressing to that TheraBand, reach and pulls. Again, incorporating in that thoracic, get good lumbar positioning, transverse abdominis, shoulders down back, cervical appropriate, and start cervical extension exercises. Just some different ideas of what we can start incorporating. The general rehab progression for our patients with the cervical procedures, we're looking at in that immediate post operative phase. Working on mobility. And, some of these patients may be home relatively early. So, those of you working in home care and outpatient, even maybe seeing these patients sooner. When we look at mobility for them, something as simple as getting out of bed, whether they're braced or not, if we have that person in hook lying and we're teaching them to scoot, bridge to lift their bottom and move, well, as they bridge, what's happening to their head and neck? We need to look at that relationship for them and be mindful of it and be careful that we don't, we're doing basic exercises and maybe they had cervical compression that led to lower extremity weakness. Watch how high up you're going with the bridge and make sure they're not pushing or straining with any of your lower extremity exercises that cervical spine, that they're not moving it into inappropriate positions, and that not they're not over tensing that sternocleidomastoid and that anterior scalene for a lot of cervical flexion or stressing movement there. We're all looking at posture. Generally, at our 4 to 6 weeks out is when we're getting to see them in outpatient PT. OT maybe sooner or around the same time. We're looking at low impact exercises for the individual, not forgetting that baseline weakness and coordination, kind of pulling everything back together. And we can get creative here. We're not just working in sitting and supine. Don't forget your developmental posture. And this is a good way to start earlier on. And patients with, again, different comorbidities. Maybe sitting, can you do sitting, resting on a table, sitting on elbows, so you're getting some weight bearing and working on that head and neck control. Can they plank against a wall if they can't do prone on elbows type of position, but that changes the forces and gains the stability in progressive different position. Then look, can you do quadruped, head and neck control, training that transverse abdominis? um, working into different base of support and lower extremity movements, progressing to tall kneeling or half kneeling. Don't forget that developmental sequence. Don't forget your PNF, head and neck control while you're doing different PNF in different developmental postures with and without resistance, because that is function, that is life. That's what they need to be able to coordinate to gain that stabilization of those muscles. If you're looking at using some type of stabilizer, I am not recommending any particular brand. This just happens to be the one that I have. You might be using a blood pressure cuff. You may have the patient in hook lying. You're placing this under that neck, inflating it, the research says, to about 20 millimeters of mercury, and you're having that patient just do that gentle nod. They're trying to use those deep cervical flexors. You're going to make sure they're not using that sternocleidomastoid or that scalene. We don't want to see that tension there. So those deep cervical flexors, gentle nod to get like a 2 millimeter of mercury increase is usually sufficient for them to isolate out that training as an initial precursor before all the other suggestions that I made. And then we're going to continue this all the way out into our phase 3, return to function, and not forgetting to increase general cardiovascular exercise as we going through here. They may need something lower impact for them, depending on their mobility level. So maybe you're going to opt for a bicycle instead of having them, go back to um, something more intense if they need to be more stable early on. Moving down, we will take a look at those thoracic procedures for adolescent idiopathic scoliosis. This is scoliosis that is developing. In the example here, we have an S curve. It may also develop as a C curve in children, usually between ages 10 to 18 years old. When they look at whether or not surgery is indicated in that child, they're going to consider that if they have greater than a 45-degree curve before they have reached skeletal maturity, then they're looking at surgical intervention. As someone moves into adulthood, they want that curve to be under 50 degrees because it progresses the curve about 1 to 2 degrees a year. So again, thinking ahead in life. For that individual. The gold standard is a fusion procedure. When we get into adulthood, if they've reached skeletal maturity or ready, they can do osteotomies and different types of resections. Where we're going to focus our conversation is on the pediatric procedures because there have been some amazing advances. And again, you may be seeing these kids either post surgically for this procedure or another diagnosis at some point in their lives, and they've had one of these procedures done. Early onset scoliosis is when the child is younger. This is a child who is under 10 years old that has developed that significant scoliosis where the bones are still growing. So the procedures need to look at allowing bone growth while limiting that progression of the curve, or trying to reverse that curve if possible for the individual. In the adult, just to reiterate, when we look at that fusion, when they fuse, like in the right image here with the rods, they're not looking at correcting the curve into adulthood. They're looking at limiting the progression of the curve. So the pediatric cases that we are going to look at and procedures are trying to look at, particularly the lower ones here. We're going to go down this way, looking at trying to correct that curve because they are younger. Flat back syndrome is something you need to be aware of for patients who have had Harrington rod placement when they were children. I can tell you back in my very early days of practice, this was it. If any of you were with me back then, the fact that there was surgery that could be done to help stabilize that curve for individuals with scoliosis was a huge advancement. This was performed between the 1960s, and then it became even more used into the 80s and early 90s. The idea is that for those patients that have that, I'll show you posterior here. Best I can do on this guy is a C curve. But if they have an S curve, there we go. The rod would come in, it goes down the entire length of the spine down to the sacrum. And we are seeing that in the middle image here. I will draw a light colored line. It's just to the left of that. So the idea was this, created stabilization of the curve. Unfortunately, what happened over time for these individuals, because it created so much stabilization, it didn't account for the lumbar lordosis. So this lumbar curve here, the individuals lost it. They lost their lumbar lordosis. Well, as you lose your lumbar lordosis, it's going to shift your center of gravity, your center of mass more anterior. Center of mass is more anterior. The person doesn't want to fall down, right? So that's going to lead to more hip flexion, knee flexion, lower that center of gravity for balance. Further up, that's going to lead to more of a forward head posture to try and balance. And it actually led to a situation where these individuals, they can't stand up straight, and that hence the name flat back syndrome. It's leading to significant degenerative joint disease for these individuals. If your patient says they had spine surgery, regardless of what diagnosis you're treating them for, you need to assess them for potential flat back syndrome, because this is very significant. It changes all of their mechanics, places them at risk for other degenerative joint disease and procedures that are necessary. They really need realignment surgery in order to restore that function for the individuals. So, needless to say, Harrington rods are not utilized anymore, but the people that had them placed, they're in their 40s to 70s now, and we're starting to see this unfortunate condition for them. Traditional growing rods are what's utilized in most cases now for individuals who have scoliosis. So, in those pediatric cases, the traditional growing rods are placed. They're going to create some stability as the individual's growing, and then they have to go in repeatedly in order to have them lengthened as the individual is growing, trying to stabilize that curve. Just to give you an example of different patients that you might see that have this done, in the image here is an individual who has Prader-Willi syndrome. um, that in that condition, it leads to scoliosis is common, obesity, there are compulsions related to food. It's a genetic condition. The individuals usually have limited activity, and we can see how this individual's scoliosis was so significant. Look how abducted that right leg is, how flexed it is in this middle image because of that scoliosis. So in patients, they're trying to look for better polymers, better tools to utilize in order to allow stabilization for these individuals so they don't have to go in for so many different surgical procedures. One option that has come up is use of the vertical expandable prosthetic titanium rib. And if we imagine the thoracic cavity of this individual, not only are their bones trying to grow, but they're not growing in a way that allows the thoracic cavity to grow. That means the lungs and the heart, they're compressed. They can't grow the way they need to, and this can lead to thoracic insufficiency syndrome. This is where the individual has a significant decrease in their ventilation capacity. This is usually for kids who are younger than 10 years old when everything's really trying to grow. Those kids that start with their scoliosis earlier are at greater risk. The idea with this type of implant is it stabilizes on the right hand image here along the spine for the scoliosis, and then it also has a rib implant to try and spread out and allow those ribs to grow for thoracic expansion so the organs can grow appropriately. The thought is that the individual with this particular procedure, that they can help improve their respiratory rate, allow the lungs to grow, have better ventilatory capacity, in addition to stabilizing the spine. Concern is with so much hardware along the spine when the bones are trying to grow, and Wolf's law, they respond to the forces placed upon them, that stress shielding is happening. So they're wondering down the road, when they remove this hardware, are those bones going to have enough integrity to them to not degenerate too quickly? The other thought that they're seeing is that, again, it limits the procedures a little bit for the patient, but it does tend to have more complication rates for individuals. There again, it's a newer procedure they're trying to figure out, but how much that stress shielding is going to play a role long term is a concern for these patients. So if you do have a patient maybe that has had this removed and you're seeing them later on, we want to be mindful if they're having any back pain or anything that may make us think that there are compression fractures or compromise to the integrity of those vertebral bodies. The magnetically controlled growing rod it's ingenious, and when if you've seen it or when you hear about it now, it's going to make so much sense. So we know that as the children are growing with the early onset scoliosis, that they're trying to avoid extra surgical procedures that are significant for them and having to undergo the anesthesia, etc. The idea is that these rods are placed in, and then there's this magnet that is placed on the individual's back when they go back to the physician, and that magnet engages the mechanism. Think of it like a curtain rod when you're expanding it, or a shower rod. It twists the mechanism and expands the rod inside the child. Fascinating, right? And makes sense for those younger kids that need this procedure. It's only in place for about 2 years for the child. Um, One challenge that they've noticed is that the rods are bending. In the image in the left here, if you look at it in the bottom image where it's showing the actual rod in the child, if you think there's a slight bend to it, right about in this area, you're right, there is. And then when they examine the adjacent tissue, they're seeing these all these little fragments on the right. And when they zoom in on them, they can actually see the threads. That there is a deterioration of those metal components and significant mechanical failure that is happening. We would think that would be okay, let's stop using this. It seems to only be at this point, this was as happened in 2021, with one particular brand of the mechanical growing rod, and the feedback from the FDA and the report that was made, again, I'll read it for accuracy. They put forward a mechanical failure warning um, from one specific manufacturer, that biocompatibility and separation is a concern. The FDA believes the benefits of the device outweigh the risks. So they still felt, because it's avoiding that thoracic insufficiency, it wasn't in all the devices, that it's still beneficial. And kids with these just need to be monitored. If they are having any unexpected back pain, they need an evaluation. We're talking very young children. So they're not going to say, yeah, I'm having some back pain. We know that if you've ever worked in pediatrics. Maybe they're more irritable. Maybe they don't like to lay or sit in certain positions. So we're going to use behavior. Maybe they're tugging at their clothes or in that area. Um, Not showing interest or desire in things that they like, as some indicators that maybe they are having some pain. Vertebral body tethering is the newest type of device that is utilized. It was only approved in 2019. Again, it's intended for patients who are still growing to try and avoid that need for a fusion surgery. And again, fascinating how this works. It reminds you of an old fashioned clothesline, which I've utilized a lot growing up. That's what we used to do: hang our clothes outside on the line with clothespins. So what they do is they insert the screws like clothespins on a line on the convex side of the curve, and what they're going to do on that convex side then is insert a line through those screws. And what they do is tighten that down so it's holding this convex side so the concave side can continue to grow. Makes so much sense. So that's, and they can just go in with not a big surgery, just go in and keep tightening that line down to try and encourage growth on the concavity for the individual. Makes great sense. It is much less invasive because it's just small incisions to make that specific adjustment. They can release it, to make it not permanent. The challenge is that this really relies on this concave side actually growing. And in some cases, what they're seeing is overcorrection the other way because the line's too tight and too much growth happened here. So they're still working on that, but it really encourages more vertical alignment, kind of using a little more of the body's natural processes. Regardless of which type of procedure the individual has, we're looking at young children into teenagers. One of the big concerns they're finding is orthostatic hypotension post surgically. And we may not be seeing these patients immediately post surgery. So if you're seeing them pre op, these are things to be aware of and do some education on. There is extensive blood loss that occurs during the procedure. They're saying in about 72% of the cases, there is some orthostatic hypotension. If you are seeing the children, you want to do that assessment as part of your evaluation. They're generally finding that it's self limiting. Increased activity seems to help, and being out of bed. And usually within 5 days, then it would resolve. We just need to ensure safety during that time, elevating head of bed, ensuring appropriate fluids, etc. Gastrointestinal complications are also a concern. We know that for any of our patients, as we increase that intraabdominal pressure when the bowels have not moved, that can increase pain in the spine. So, making sure that individuals are ambulating, hydration again. There was a 5 year retrospective analysis at one facility that looked at the reasons for ER visits following the different scoliosis procedures. And they found right up the top there within the first 6 months, dehydration and pain related to that constipation were high on the list. So we need to address those. There was a Delphi study method that went through the Emory University. It was funded through the American Academy of Orthopedic Surgeons because they wanted to figure out what are the best practices after scoliosis surgery for the children. And related to this bowel movement, they actually suggested chewing gum. So you could almost use this as a reward, right? They don't want to get up, they don't want to move. Well, maybe you left the gum out at the nurse's station and we have to walk there to get it. Chewing gum increases gastric motility, and they found that these patients had their first bowel movement 30 minutes earlier to get things going. Ambulating early, getting into that bowel regiment to make sure that that is moving, removing the drains as quickly as possible, limiting those pain medications as early as possible, getting off that, PCA to oral pain medications. As we look at rehab, we need to definitely address that pulmonary function for individuals. You're doing your diaphragmatic breathing, your pulse lip breathing. Some studies were looking at, well, what is the best protocol for those? They didn't come up with one specific, but the trends seem to be that when you're doing a diaphragmatic breathing, an exhale of 4 seconds, and with our pursed lip breathing, an exhale of 7 seconds. 3 times a day for 10 minutes. They found that the forced expiratory capacity increased and their expiratory volume increased, PO2. They found, though, that kind of sticking with this protocol, that it took about 6 months to see those significant changes in respiratory capacity. Again, something that could be instructed earlier or at minimum needs to be part of your post-op management. Now we'll move further down the spine to our lumbar region. As we look at the different lumbar procedures that can be performed, we have our basic discectomy procedure. This can be a full or partial removal of that disc that has deteriorated for that individual. Laminectomy, we'll discuss taking out that segment of lamina that is creating that stenosis or compression. Um, so we'll also look down at the foraminotomy, opening up that space in the foramen. The goal of all of these, again, just like in the cervical area, is decompression to relieve pain, sensory changes, and motor changes. Full endoscopic lumbar discectomy. This procedure is focused on being minimally invasive. The idea is to enter the spinal cord as close as possible to the area where the procedure needs to happen to minimize the amount of trauma and involvement to those adjacent tissues. So that's what FELD is. That means it's fully endoscopic. From there, actually where the physician is going to enter, there are two different options. The physician can enter through the foramina, so then it's a TELD procedure, and then on the bottom third image from the left here, they are going to enter through that area, through the intervertebral foramen to be able to remove these segments here that are encroaching. So on the far left image, we're seeing encroachment, and then we see restored signaling here to actually take out those specific fragments. The interlaminar approach, that is going to actually come in this top right image between the two lamina. I mean, look at the size of the tools the physician is using. It is so small. And they say there is a significant learning curve with this for the physician. If we look at this right image here, just to give us an idea, I'm squaring out the degenerated disc. And then the next area in green here is that ossified posterior longitudinal ligament. And then up here in yellow, this is our nerve root. And that's because I studied this image. So we can imagine the skill it takes from the physicians to perform this percutaneous procedure is significant. But the idea is that it'll enhance recovery because it is less invasive, less traumatic to the surrounding tissues. In terms of the outcomes that they have seen from the full endoscopic procedures, looking at comparison to a microdiscectomy going through the foramina, they did find that pain and disability were similar, but the length of hospital stay was less with the more minimally invasive procedure. The difference was, again, it's data. So it's zero point 0.7 day stay for the TELD procedure and a 1.4 night stay for the microdiscectomy. May not sound like a big difference, but it's 50%. And when we think about being discharged means less risk of infections, less strain on the hospital's system, workers, etc., and the patient's up and moving more. So that actually is pretty significant. A longitudinal review here looked at really over 5 years, patients were doing about the same. The pain changes that were noted in this, and they used the visual analog scale, they looked at an Oswestry index, patient satisfaction, everything came out about the same. But they did find that in terms of pain, patients were at almost an 8 in their baseline pain. That went down to a 1.7 pain level about 6 weeks postoperative, so significant gain there. It went down to a zero point 0.8, so below 1 at about that 1 year mark. After that, the pain went up slightly to a zero point 0.9, and then it went up 5 years later to a zero point 0.99. So, still significant improvements for these patients. Looking at the fact that we might unfortunately see more procedures needing to be done on adolescents and young adults because of the obesity epidemic, they did do a comparison study on obese versus non obese adolescents to see the safety more so of the procedure. The function and hospital stay remained the same. So, what they discovered is that there was no significant greater risk for the individuals or children who were obese, which is great. Obviously, we want to be more on the forefront of limiting that, but if it does get to this, they're finding no greater risk of complications. They did, however, note that there was longer term restriction of activities and longer bracing support that were utilized for the individuals with obesity. So just some modifications, but there's hope there for this procedure for that population. If the discectomy is not sufficient, then we're going to move to a lumbar interbody fusion in order to provide stability and pain relief and improve function and quality of life. Just a little timeline here to see our changes. The first laminectomy was done in the 1800s. That's so amazing. Then we went through to see bone grafting in the 1900s. Screws and hardware were becoming more in the 30s and 40s. But actually, in the 1970s is when we started with some endoscopic procedures. And then more of the contemporary devices that we see in the 80s to 90s is when we saw more of those interbody devices. And mixed in there were those Harrington rods that we're not seeing anymore. In terms of the lumbar interbody fusion, there are several different approaches that can be utilized. There is going in anteriorly through the abdomen, laterally, which again is through the abdomen, or extreme lateral, just a little further, and then posteriorly, either just going generally posterior or through the foramina. The 2020 North American Spine Society guidelines says, for their grade 1 recommendation, again, there's insufficient evidence to recommend one procedure over another as to which technique results in the best outcomes for decreasing duration and intensity of pain or for increasing function with improved return to work. No studies adequately address if there is any benefit of bone growth stimulators or if fusion is a better outcome compared to discectomy. So that leaves it to the physician's decision making. The goal with the lumbar fusions is that arthrodesis, in order to help stabilize those segments, take some of the pressure off of those nerves, like in that cervical region, so that we're relieving pain and restoring sensation and weakness. And with fusions, they are looking at restoring the disc height in that area through instrumentation and grafting. We'll examine each of these approaches, starting with our anterior approach. This is more of a direct access approach. We're on the far left image here. That incision is going into the abdominal area, and the next image, they're going to retract this open. We can imagine with this anterior approach that there are a lot of organs that have to be moved out of the way. That retroperitoneal access that needs to happen to allow some visual field in that area is necessary because all of that vasculature is being shifted and moved. There's a greater concern of vascular complications. So, post operatively, we need to monitor these patients for any abdominal distension, tension in the abdominal area, if there might be a bleed that has occurred. Their physician also considers that this is a posterior view, but just to show you, those kidneys are located here between about T12 and L3. So, for this approach, when they come in, they're going to be doing the lower lumbar segments, not those upper, because they really don't want to move those kidneys around. That hepatic or renal vessel that's coming in is at greater risk of a clot formation. So they're going to stick more for the lower lumbar procedures, L45, L5S1, for this approach for the individual. When the physician comes in for that anterior aspect, they are able again in this middle image to clean out that end plate, place in that interbody cage along with its grafting, and then they're going to use the pedicle screws here in order to create stabilization in that area. The advantage here with this approach is they're not moving all of that posterior musculature, so there's less of a concern with pain in the back area from that muscle involvement, less trauma to the psoas muscle, so less post-op pain for those individuals. So hopefully there's greater mobility. But again, we really have to be careful of that vascular compromise. So not only are we monitoring that abdomen for any distension or tension, we're monitoring patients for orthostatic hypotension should be part of your assessment. And early on ongoing, looking for any anemia or signs of anemia that may be present. The lateral approach is where the patient is going to be side lying. Those hips and knees are going to be flexed up for the individual. And then the physician is going to do just that, come in laterally for that patient. As we look at the different musculature in the area on our vertebrae here in the lumbar spine, because this procedure can be done at slightly higher levels in that lumbar area. So they're going to come in, and we're going to be mindful that we have that quadratus laborum sitting here on those transverse processes. And then we also have coming here that psoas muscle that's coming down. And in between there, we have our lumbar plexus. So the concern is that there can be some trauma sustained to that lumbar plexus, as well as the psoas muscle located in this area. So as they're coming in laterally for this procedure to get down to that spine, they are going to do more EMG monitoring, specifically to monitor that lumbar plexus. If patients already have had peritoneal surgery and they have a lot of scar tissue in the area, that's going to make this approach more difficult. So the physician may opt not to take this specific approach. They can access, all the way T12 down to L5 for this, L4-5 for this area. They're trying to use different types of dilators to move those muscles out of the way instead of retractors, so they sustain less trauma. One study had physicians on cadavers perform the lateral approach, and then they assessed the integrity of the psoas muscle as well as the lumbar plexus. And they did find different amounts of trauma to those tissues. What we're going to monitor patients for that may lead us to think that psoas is having some trauma to it would be that deep-seated psoas pain, and then the individual is going to have those challenges with hip flexion. So if they're sitting just doing hip flexion, going upstairs, stepping up onto something, if they're stepping over that threshold into the shower or into another room, that is going to present a challenge for them. Just to give you the data on that study that they did, they performed 26 procedures and 15 of them had different traumas to that psoas. So we do need to be cautious in monitoring that for those patients. The other posterior approach that we are going to look at has the patient that is going to be lying prone during the surgical procedure. This gives the physician excellent visualization right down to all of the tissues that they need to assess and different structures that they need to remove the osteophytes and decompress from. So they might go in and do a bilateral procedure, which is the posterior approach, where they're going to do a laminectomy bilaterally in the center image on both sides. And then the TLF is where they're just going to do it unilaterally on one side. The thought with that is, depending on where the degeneration is, they may just be able to remove the lamina from one side. And then by retaining all of the ligamentous and other stability on the other side, it just may make that fusion a little bit more stable down the road. Either way, they're going to go in, they're going to remove the ligamentum flavum, clean out the other ligaments, remove that disc that has fragmented, herniated, deteriorated, etc. Going to clean out those end plates of the bone to give a good seating for that interbody cage and grafting to be added. And then what they're going to do is add those pedicle screws. So we see here that same thing with the cervical. When they go in posterior, they're adding those pedicle screws, and we see that at my arrow tip here on the far right image. And then when they add the bar, they're able to maneuver that in order to work on restoring that lordosis for the patient if they have that spondylolisthesis that is present. Again, the concern here is they're dissecting through all those muscles. So we do expect that this patient may have a little bit more muscular pain. We are going to monitor them during rehab for any adhesions that may develop in those muscles, any adhesions that may occur, scar tissue around the nerves in that area. So we're just going to be mindful of that more so with this posterior approach. Something that's utilized more commonly after many different procedures, but particularly for lumbar spine surgery, they're looking at enhanced recovery after surgery. The definition of this management strategy post-operatively from the American Academy of Nurse Anesthesiologists is, it describes it as looking at a patient centered approach that is going to be a pathway to reduce patients' post surgical stress response. So the idea here is to give them an optimal recovery opportunity through several different mechanisms because surgery is so traumatic and stressful to the body overall. So, preoperatively, what you may start to notice, and again, looking at the involvement that patients have, how we can play a role, they're looking at carb loading, where they're going to give the patient different IV with carbs in order to be prepared for healing post operatively, modifying fasting, where the patient 6 to 12 hours before surgery may still be allowed to eat, liquids 2 to 8 hours before surgery. So we want to know if your physicians are utilizing this, if we see patients preoperatively, to educate them and then make sure they have access to the food and things that they need. So the idea is they're trying to help regulate and prepare that physiologic response. So perioperatively, they're controlling blood loss. They're working on, again, fluids, looking at the medications that the patient is giving. Instead of just morphine and pain medications being utilized, this approach is focusing more on neuropathic pain medications and mediators, looking at in giving the patient that 1 hour prior to the surgery so that they're prepared for afterwards, looking at less opioid use to help control that constipation that we know increases pressure and contribute to greater pain for our patients. Post operatively, we know getting patients up and moving early. I can remember the days where patients were in the hospital for 10 days was nothing for so many different procedures. And anyway, we've grown a lot, we've come a long way. But this recommendation is day of surgery, patients should be up and moving. After a laminectomy, the goal with this is to have the patient within 90 minutes of surgery to get them up and moving, or with that microdiscectomy to have them up and moving. So that early mobilization, and again, nutrition. So see if your patient needs referral to outside sources, to have access to their food. Are they able to physically get up and prepare it, etc.? And that's good for all of our patients. The outcomes that they're seeing for individuals who do have this type of management of their surgery for lumbar fusion, they're seeing less pain medication use, less of the PCA usage for that individual. Comparing microdiscectomy and fusion, with or without this method of management, they're seeing less adverse events, and not being readmitted. And it's important, I think, that this particular study looked that far out, that, okay, yes, we got them out faster, but are they having readmits? And they were finding that patients were not. Less adverse events, that shorter length of stay, and they were not needing to come back in. At one facility, they found that their one night stay went from 26% of patients down to 85% of patients, and again, without those readmits. There was a review that looked at both cervical and lumbar, all different procedures. And again, they saw that same trend, that none were associated with worse outcomes, and they saw less opioid, less length of stay for patients. Another one of the studies, and I forget which one it was, but part of the idea with this regimen is it decreases the inflammatory response or helps regulate it. And they did find, when they looked at the lab values, that the C-reactive protein levels were lower, indicative of less inflammation. And that's part of all this, to make sure that the patient has the right proteins and carbs and components for healing to start right away. Same thing with the cervical spine, looking at lumbar bracing. The consensus is there is no consensus. um, that there was a large systematic review from 1990 to 2019. So everything changed significantly in that time period. And they really found that they couldn't lean one way or not. The idea is that the bracing decreases the biomechanical loading, hoping for that better fusion. But if it's utilized for too long, there's going to be more atrophy, and then we have skin integrity concerns for the individual. um, Pulling some of the actual studies to try and give you some different data, This is looking at that long-term study, over 30 years, and they did find that there was no difference in the pain and disability levels for the individuals. Looking at that TLIF, so that's the posterior approach compared to the control. It was a prospective study, 90 patients, decent size cohort. They used the Oswestry, the visual analog scale. They looked at complications. They looked at radiologic examination of fusion rates, not finding any difference. Kept looking, hoping for another answer. And these are just the studies I'm referencing. Not if you're curious about all the research from all these different studies. If you go to the end of your course notes packet, everything is listed. As well as on some of the slides. I did find a survey of surgeons, and they did it at a national conference of surgeons in 2009. And they said, are you using bracing or aren't you using bracing? And what they found with the different surgeons is that currently that 60% were not using bracing for their patients. When we went back and looked at the data from earlier on in 2009, they really found that there was just inconsistent. It didn't go one way or the other. So definitely now there's a leaning towards not bracing, but again, it's a discussion to have with the physician, surgeon. In terms of postoperative management, when we look at the different interventions for our patients, again, the push for non pharmacologic management of pain, looking at relaxation exercises. Really, with the lumbar spine, they also found just getting patients up and moving, getting them, between post up day 1 and post up day 3, they really need to be increasing their ambulation distance slash time. And what they're finding is patients who did that, they were having less urinary retention. So that is less pressure, less ileus, less pressure. That leads to decreased pain, less pain medication use. So they're kind of breaking that cycle. And they also found that then that getting them up and moving earlier, it didn't put them at a greater risk of more readmissions, that it was actually more beneficial for the patients. In terms of activity restrictions and what are patients allowed to do or not allowed to do, research is kind of the same way, that there wasn't one specific protocol or one specific you can or can't lift this much or do that much, that it really varied with the physician. Where there is consistency is to look at using abdominal exercises, focusing really on that neutral spine control for the patients. They did find that patients who participated in the activity, these particular components of their rehab program, did have better outcomes, less pain. What that rehabilitation progression might look like early on post operatively. We're working on that log rolling with the patients, starting lower, maybe 15 minutes, getting up to 30 minutes with that walking program. Your basic exercises, long arc quad, isometrics, etc. Focusing on engaging that transverse abdominis. That can start early, looking at just a small amplitude contraction of that transverse abdominis with the patient in supine, using our verbal as well as our tactile cues, doing that little small range pelvic tilt, then progressing the individual into seated, again controlling that transverse abdominis, and then as they go through rehab, progressing to doing upper extremity exercises, movement patterns, PNF, weight machines, uh, to do those activities while controlling that pelvic motion. Looking at weight bearing activities with those, working on squats and lunges, because that's sit to stand, that's movement, being able to engage that transverse abdominis appropriately. If we're looking at, again, using some type of blood pressure cuff or pneumatic mechanism as feedback, if we are looking at supine performance, placing this under the low back, we're Again, there's variability, but some of the different protocols out there are looking at pumping this up to about 70 millimeters of mercury. And then when the individual engages that transverse abdominis with that little pelvic tilt, I'm sorry, 40 if we're supine. So 40 millimeters of mercury if we're supine, and then they're going to increase that pressure about 4 millimeters of mercury. You can also do this in prone for your patients, a way to engage a different way. So you place it prone under that abdomen, then you need to increase it to 70 because they have more body weight on there. And now as they engage that transverse abdominis, the pressure should decrease because they're moving away from that weight. So we want to see a 6 to 10 millimeter of mercury decrease in the pressure. So maybe if your patient just isn't getting it in supine, you can try them prone again. Watch out for respiratory compromise, etc. For that patient. Total disc replacement may be an option for some individuals if these other procedures are not successful. The concern with fusions is it needs to become a solid fusion, and then over time, the individual can have adjacent segment disease develop because there's movement isn't occurring everywhere and more movement has to happen there and the stresses are placed through differently, so they get degeneration. The idea with the disc is that it is going to avoid some of that because it retains the range of motion. We don't have to worry about the fusion rate in terms of bone grafting, and there's less risk of adjacent segment disease. So, if we look at are these procedures actually being utilized, if we examine the cervical disc replacement procedure, the CMS guidelines indicate that there is coverage determination for patients with intractable cervical radicular pain, failed conservative management, so that's minimum 6 weeks of rehabilitation. And if they have progressive symptoms, then there are ANDs. They need to have nerve root and spinal cord compression. On examination, it's only indicated for C3 to 3/7, and they cannot have any contraindications. So, extreme obesity is considered a BMI that is greater than 40. So, if you're working with a patient to try and become eligible, we're looking at getting that BMI below 40, and they can't have osteoporosis because then there wouldn't be good adherence. If we look at, yes, it's covered under these circumstances, there's debate as to, is it really beneficial? There are some surveys that looked at it, and many physicians are still utilizing the anterior approach because they're finding that it's still as beneficial right now. Um, who knows what we're going to see in the future? And they are very selective in the patients that this is a covered procedure for. In terms of the lumbar area, there's not as much success. As of us talking about this during this recording, the national coverage determination is that it is not covered for individuals over 60. For those younger than 60, they're looking at it being a local coverage determination. Most of the local coverages are saying no. And again, the reason here is that they're saying the research hasn't found any meaningful change that makes this a better procedure than what is already being done with the typical fusion procedures. So again, maybe we'll see that change in the future. I do want to mention two procedures that are completed for compression fractures of the spine. The vertebroplasty. This is what when someone has, an osteoporotic fracture or compression fracture for other reasons that just hasn't healed. Those fragments can be a little loose and move around, and that can create pain, additional compression. So a vertebroplasty is really trying to address that chronic pain. It's not trying to enlarge the vertebral body. So it's trying to stabilize those segments. So they are going to inject in this middle image like a cement, and that is going to just stabilize those segments, those fragments, I should say. Kyphoplasty is different. This is done when they still feel that it's early enough after the fracture that they can restore some of that bone height to improve alignment. So it's like a little spring kind of mechanism that I have it imaged up here. They implant it and then they compress it so that it actually enlarges that disc height. In the far right image, we could see it. Then they put pedicle screws and rods in order to sustain that. The patient's usually in physical therapy within 2 weeks of this procedure. So, general rehab considerations for our patients who undergo all of these different procedures, we're going to take a look at. I do want to, again, emphasize the benefits of physical activity. We're looking at cardiovascular fitness. These are patients who probably haven't been doing a lot. So, as part of our rehab, we don't just want to focus on return to ADLs, return to work, spinal stabilization, strengthening, balance, all of that. We also want to look at coming up with a general cardiovascular fitness component for the individual. Also, look at when they look at the research that individuals who are considered super obese, who have a BMI greater than 50, they are at a significantly increased risk of complications from these procedures. So, if we are seeing them pre-operatively, we're looking at trying to help decrease some of that weight for them because they're more likely to have greater pain post-operatively, more risk of wound dehiscence and other infection complications. That also lets you know what to monitor those patients for. Incision, we are going to take a close look at. I want to highlight individuals who have sleep apnea, where they're on a CPAP machine. You need to make sure that they are able to wear that machine. Can they get to it to put it on? Do they need someone to help them? Because individuals with sleep apnea are at a 2 times greater risk of DVT and pulmonary complications. So make sure your breathing exercises, regardless of the procedure, your DVT prophylaxis really needs to be significant in these patients. You're going to monitor your patient for any worse radicular symptoms post-operatively. We need to distinguish those from what was already compromised before surgery because it's not magic, right? It's not going to be better right away versus something that may be one of the complications that we have talked about. And then again, making sure we keep an eye on that bowel and bladder and that development of pseudoarthrosis where they're not fusing, where they have pain that's happening that just doesn't fit. Something else to think about, again, why on all our patients, we need to be looking at their face, head, and neck area. Perioperative vision loss is a complication that can occur post-operatively for patients who have had surgery in the prone position. So those would be our post-operative patients. It does seem to happen immediately post-operatively. The American Society of Anesthesiologists put out a practice advisory related to this. That's how significant significant a complication it is, it can be devastating to the patient with loss of vision. What happens is when the patient is prone, and again, they're doing everything they can to avoid this, but they have that pressure over this ocular region. Because of the ocular compression, it increases the pressure in the eye. That is going to create vascular obstruction were to the retinal artery, less blood flow in, venous congestion less out. Now you have that optic nerve that is compromised with ischemia, and it can lead to vision impairment. What we're going to monitor our patients for postoperatively, if their eyes look really puffy and irritated, that would be of a concern. We're going to do, a basic vision exam if we're concerned about that. But a quick assessment that you can do, and with your cervical patients, we already said you're looking at that pupil reflex and if there's dilation. That when you switch the light to the eye, like let's say we put the light on the left eye, the right pupil is the one that's going to react. So you're going to see dilation on the opposite side as we switch our light, would be indicative of this. And we definitely need to refer that patient because this can be potentially devastating to their vision. In individuals with a lower nose bridge, for example, those with Asian descent or someone with exophthalmos, if they have a thyroid condition, they're going to be at a greater risk. Medication and diets we know are important. Looking at patients should not be driving if they are on narcotic medications. Several states actually have rules and regulations regarding that. If our patient is unable to do their ADLs independently, do they have enough mobility to really be driving? We know those are the tough conversations we need to have all the time. Generally speaking, pain starts to subside in about 4 weeks, and then it takes about up to 8 months to really see that pain dissipate. That constipation we've mentioned several times. We want to make sure patients have enough intake of protein in their diet. Make sure they can physically feed themselves, prepare it. Do they have food insecurity? They need community resources to get that food. This might not be a population that you would think of as at risk because we've talked about the concerns with high BMI, but individuals with a low BMI who are underweight, they're at greater risk for surgical complications. And this can apply to adult as well as our adolescent patients. What they're finding is individuals who have different nutrition or just a metabolic condition where they have a very low BMI, they tend to have a lower bone density because there's less forces upon those bones, and they're also finding lower protein levels. So their bone just isn't going to heal as well, potentially. Also, they're finding for some reason that the immune response and clotting is limited in individuals with these low bone weights, low body weights. And then that puts them at a greater risk for deep infections, for renal compromises and complications. So we do need to be aware of this. Again, looking at that access to food for patients. Tobacco use, we know this is not beneficial for any of our patients. They need to be avoiding not just cigarettes, cigars, e cigarettes, chewing tobacco, any of the smokeless types. The concern really is pseudoarthrosis, where they're not going to have that good fusion. The research varies, but it says that there's a 2 to 3 times greater risk of pseudoarthrosis in someone who uses tobacco because of that delayed healing, risk of infection, also. We know that nicotine is directly going to impair those osteoblasts, that formation of the new bone matrix for that individual. The bone that does seem to form has less tensile strength, so that's going to limit its ability to hold. The endothelial damage in the inside of the lumen of the blood vessels means that there is going to be less vascular supply going to those healing tissues. And then the individuals are at a greater risk of clotting because those platelets tend to aggregate more. All of this put puts these individuals at a lower risk of healing, increased risk of infection, and generally speaking, individuals tend to be less satisfied with the ultimate outcome of their surgical procedures. As we look at our mobility restrictions for patients, we know that we are focusing on postural alignment. In regardless of where they have had the surgery, cervical, thoracic, lumbar, we need to bring all of that back together and be able to retain that postural alignment with moving through different positions, different developmental sequences. Lifting restrictions, again, are going to be dictated more by the physician. We're looking at adaptive equipment as necessary so they can maintain those mechanics, not violate any movement or lifting type of precautions. Make sure that if we're giving the patient a reacher, do they have the dexterity to execute that? Um, the general rule is we're not having any BLTs. So we're looking at no bending, lifting, or twisting postoperatively. That also extends out to pushing and pulling. Think about opening doors to the car, to rooms. Look at how heavy are drawers. If someone's, maybe they're starting to get back into food prep and they have the pull out shelves in their kitchen, but it's loaded down with 20 cans of vegetables, etc. That's kind of heavy. That they probably shouldn't be moving that. As we said, individuals with sleep apnea, make sure they have that cord placed appropriately so it's not pulling them in a specific position. Look at hip alignment in sitting. Again, just in all different positions and activities. Some of these may be patients who are still out and working. Look at the ergonomic setup of their devices and equipment that they're using for return to activity. In terms of general physical activity level, it was curious when I read the studies. Our thought is that we educate our patients, we come up with a discharge plan, we have them do all these activities, that over time they would naturally translate that and that would carry over to a general increased activity level. Unfortunately, the research is not showing that for our patients that have spine surgery. So, a couple of studies, one looked at patients who had lumbar fusion procedures done, and they monitored these individuals with accelerometers to see how much they engaged in like moderate and vigorous activity. And what they found is that the physical activity that individuals participated in, that there was really no change from 6 weeks post-op, how much activity they were doing, to 3 to 6 months. Their function was getting better. They were doing their ADLs, they were doing their work activities, they were doing what they needed to do, but in general, they weren't out doing more leisure or like what we consider exercise and cardiovascular activities. It didn't just translate for them. So what this tells us is we may need to be more specific in that component of our discharge plan, or even starting it earlier, our exercise program, to make behavioral changes for our patients and incorporate more strategies for walking programs, community programs, recreational activities to increase their overall function. Not just function, I should say, their overall physical activity level for general health and wellness. The other study looked at both lumbar as well as cervical patients, and what they found is that in about 12 weeks, their function was about back to what they were pre-operatively. But beyond that, they really didn't again change much of their activity level. The data from this study, again tracking the steps on the patient, that 1 week post-op they were only doing about 30% of the physical activity they were before surgery. By the second week post-op, they were doing about 60% of the physical activity they were preoperatively. Great. 4 weeks post-op, 75% of their general activity preoperatively. But if we continued that way, by another month or so, patients by 6 months, they really should be back to their prior level and then doing more because that's why they had the surgery. Wasn't happening. Even looking at patients a year out, many of them didn't increase their general activity level. And then that was unfortunately associated with increased rates of depression. Again, opportunities for us to be more comprehensive in our rehab. And if you're looking for opportunities to have more community engagement or programs, this might be one to consider. As we move on to some emerging techniques, they're looking at expanding the use of technology, not only for imaging, but also for the instrumentation that is utilized. Skin anchored intraoperative navigation. Currently, fluoroscopy is what is utilized to give the physician a visual of what's going on with the anatomy. And they're looking at, and they have come up with, they're testing it. It looks like this picture frame that they put over the spine region of the patient, and it does site mapping. So it's integrated with web software that is going to capture and generate a 3D image of all of the anatomy. So the physician can utilize that before surgery to kind of plan their approach, pre plan their procedure, and then continue to use it during the procedure just to help decrease the operative time and increase the outcomes. 3D printing is everywhere. Not surprised, they're looking at utilizing it for the spine. They're looking at making a truss design, like on the right here, with 3D printing, so that the implant will directly match the patient's anatomy. And we said they want to try and use as much surface area as possible to decrease the stress shielding, increase the force and stress distribution for better fusion, less adjacent segment disease, and for just better graft placement. So they're looking at using 3D printing to accomplish that. And then lastly, they're looking at interspinous process devices. And again, this makes so much sense once you read about it. So all the procedures that we're looking at are focusing on, making up for this disc that has degenerated, increasing that space, opening up the space in the intervertebral foramen, the vertebral foramen. Well, this device says, either in conjunction or as an alternative for patients that can't go under these procedures, well, if we can't lift it up from the front, why don't we lift it up from the back to go in between these spinous processes here and kind of separate them out? So they're coming with interspinous process as well as interlaminar devices that can open up more posteriorly. And in the bottom image here, you can see it kind of reminds you of like the edge of a binder clip, kind of those loops that come out that would pressure out that way. for patients. The outcomes aren't well explored or well established yet, but the idea is that it can help with decompression in the area, and it's something that we might see being utilized more in the future as they get more research on this. What we've done in our discussion today is examine the degenerative conditions that lead to spine and nerve root compression, impairing function for our patients and increasing their pain. And then we extended that to look at the surgical interventions to help alleviate those symptoms and improve quality of life. And for each procedure, hopefully, you have a better understanding of what your post op considerations are and some ideas of rehab to help increase the benefits of our rehab for those patients. How are patients responding to artificial disc replacements? When we look at the cervical region, when the artificial disc is utilized instead of the interbody cage, particularly from the anterior approach fusion, the with the artificial disc, an anterior plate is not required, and the adjacent vertebrae don't need to be stabilized in that way. Because of this, the thought is that the artificial disc not only retains the anatomical disc space, it also helps maintain the normal lordosis without that extra hardware. And then physiologic motion is still permitted at that level as well as the adjacent levels. There's been several different long-term studies that have examined this, particularly for the cervical region, and they have shown good clinical outcomes in terms of biomechanics as well as clinical data where the motion is actually preserved at those adjacent levels. And that's just looking at patients who are having the artificial discs in the cervical region for one or two level spondylosis or spinal stenosis, along with radiculopathy. Some of these studies have even followed the patients going greater than 5 years out, still seeing preservation of motion and long term clinical benefits. In the lumbar region, the results are a little bit different. The research indicates from CMS that there is a concern over determining really what's a clinically important change in the research to determine the effectiveness. The again thought is that it will still allow the adjacent segments to move as well as the segment where the procedure was performed, so there's better distribution of force is the theory. However, the research, according to CMS, really isn't finding or hasn't explored in depth enough if that theoretical idea that they do see on imaging translates into better function for the individual. Is it really clinically meaningful to the life for that individual? Also, they're finding that the procedure is performed for patients who do not have spondylolisthesis or spinal stenosis, which we know often are concurrent. So it's a different patient population so far where they're performing the lumbar disc replacements. Ultimately, what CMS indicates is that the research does not have any meaningful information to support that the cervical disc replacement is superior as an alternative to either conservative management or the fusions that are already being performed. Do you think an ACDF is half surgery and incomplete, not the whole job? The anterior cervical decompression infusion procedure, I definitely would not have to defer to the physicians and I would not question their decision making. They're going to look at the imaging, looking how the patient's presenting, as well as the available technology to determine what's the best procedure for that patient based on their comorbidities, functional goals, pain, etc. With that, just to look at maybe what you're thinking about as it being like half a procedure. Whether the anterior or the posterior approach is completed in the cervical region, it is going to target different structures. And that's part of the determination for the physician which procedure to go with, anterior or posterior approach. Both of the approaches are going to remove the disc, clean all the osteophytes off of the end plates, and decompress portions of the vertebral canal as well as intervertebral foramen and work to restore the lordosis. Where the difference is arises in terms of maybe more of the ligamentous structures that are removed. So the physician would see where they feel the compression is coming from in order to see what needs to be relieved. In the posterior approach, that lamina, intervertebral foramen are more accessible. The lamina can be removed, the ligamentum flavum, if that is causing some neurogenic compression for that patient, neurogenic claudication. Do they see that they need to work more on those posterior structures to open up the space? They might choose that approach. If the posterior longitudinal ligament is more where the pathology is creating pain and neurologic symptoms, then the patient may undergo the anterior approach for the physician to more readily access those areas. Why aren't Harrington rods used anymore for scoliosis? Back in the 1960s into the early 1990s, they were considered very innovational to allow teenagers with scoliosis an alternative to bracing and then have more long term alignment. Unfortunately, as those individuals progressed in life and moved into mid and later adulthood, who we're now seeing, unfortunately, they started to develop restrictions of trunk motion that ultimately did not allow the individual to stand up straight and have that erect standing posture. While the rods that ran all the way from the sacrum all the way up the vertebral column, they could stabilize and prevent the progression of that S or that C curve. Unfortunately, what happens is they maintained rigidity along the lumbar lordosis also. So it didn't really allow the individual to have a lumbar lordosis, which we know is important to have, head over shoulders, over hips, etc., to align that chain. And what happens over time is they notice that individuals then losing that lumbar lordosis, their center of gravity goes anterior. So they have some hip flexion, knee flexion. Then they're going to have more of that flat back posture, have a forward head and extend it up to be able to see. And over time, these individuals just aren't able to stand up straight. So that's why they have stopped utilizing the Harrington rods and the newer technology that's utilized for children that are younger. They're looking at more growth friendly alternatives in terms of the hardware. Why do some surgeons require post surgical lumbar bracing and others do not? I wish I had a very simple and clear cut answer for this, and I've read a lot of research on the topic. And it probably fits with what you already know, but just to reconfirm that, there really are no specific guidelines available related to provide that lumbar bracing or not after that lumbar fusion. It really comes down to the individual surgeon's preferences and what they see as working better based on their patient population, the surgical approach, the hardware, grafting, everything coming together. If we look at the actual research studies that have been completed, the studies are not really showing any significant difference between patients who are braced versus not braced. Looking at the rate of fusion, complications, if reoperation is necessary, and then also looking at the patient themselves in terms of their functioning, most of the research is not finding whether you patient had your patient receive a brace or not, that they had differences in their ultimate level of disability, pain, quality of life. They're really not seeing a difference. Many of the research studies then conclude if there's really not a difference, there's probably not a need to brace. Again, it becomes the physician's decision at that point. There was a more recent study out of the University of Pennsylvania looking specifically at the posterior approach lumbar fusions at multi levels and looking at the short term postoperative course. There was really no difference again. It also did not change any adverse effects in the early stages of recovery for the individual. Overall, there does seem to be more of a trend towards not bracing. Some research finds it's a 50-50 split. Other research finds it's a 60-40. Don't brace, do brace. Really, there are just inconsistencies in bracing practices, which is why it's important to know the physicians and surgeons that you work with, know their protocols, their rationale, because we know our patients are going to ask us, especially if they're sitting right next to each other in the clinic. And it's important that we are able to explain that in order to achieve compliance. How do cervical patients shower if the collar is to be worn at all times? Excellent question. Generally speaking, patients are waiting those 3 to 5 days for some incision healing and the dressing to be removed before they're even attempting the shower, making sure they're stable in order to accomplish that. Once all of this is achieved and they still need to have that collar on at all times, often the patients are going to be prescribed an aspen collar or some type of custom collar for during the day and to sleep in that will help restrict motion if the physician decides that's necessary, and also be padded to limit the potential for cervical breakdown. On the other side, then when they need to go shower, patients may be prescribed that Philadelphia collar. It's the basic foam collar that you could then dry off in between when they put that aspen collar back on.